All right, so we're going to talk about reverse total shoulder arthroplasty. I don't think there's anything in shoulder surgery that has been more revolutionary or transformative than the evolution of a reverse total shoulder. Everything else we do, from rotator cuff repairs, have been done for decades. A reverse total shoulder allows us to do more than we could do before. To understand a reverse total shoulder, we need a short little physics lesson on how the shoulder works. I apologize for that. The shoulder is a glenohumeral joint, so you've got the ball in a very shallow socket. And the shallowness of the socket allows great range of motion of the shoulder, but it also creates a tremendous amount of instability. That instability can be overcome by the rotator cuff. Muscles have force vectors. They work in line with their muscle. The entire rotator cuff, from the supraspinatus, the infraspinatus, teres minor, subscapularis, all of their force vectors are designed to hold that humeral head in the glenoid so that it gives a stable center of rotation. That stable center of rotation then allows the deltoid to work to rotate the arm upward. If you don't have that stable center of rotation, the shoulder doesn't work. So the problem is this. If the rotator cuff creates a joint reaction force that holds the humeral head in the glenoid, when the rotator cuff is missing and the deltoid starts to pull, instead of that humeral head staying in the glenoid and the arm rotating up, the humeral head just simply slides up. And when that happens, you get an x-ray that looks like this. On this side, you have a normal x-ray. The humeral head is sitting here, the rotator cuff is sitting in this space, and the humeral head's right where it's supposed to be. On this side, you can see that the humeral head is right up against the acromion. And in fact, it's been there for so long that instead of a greater tuberosity here, it's rounded off the humeral head. We call it femoralization. It starts to look more like a femur. And that only happens when there's a massive rotator cuff tear. The humeral head is sliding up against the acromion and it's starting to wear things away. Clinically, it looks like this. You can see this extremely unhappy patient who's got a left arm that works great and a right arm that doesn't work as well. This is what we call pseudo-paralysis. It looks like their arm's paralyzed. They try to lift it up, their shoulder just shrugs. They can push it up with the other hand and it falls right back down. And that's the problem that can be created with a deficient rotator cuff. Rotator cuff deficiency can have multiple causes. By far and away, the most common cause of a rotator cuff deficiency is a rotator cuff tear. This is looking from the back of the shoulder. The rotator cuff is here. The rotator cuff should be attached to the greater tuberosity, and it's not. And if it's not attached, the muscles can't work to help hold the humeral head and the glenoid like it's supposed to. By far, that's the most common cause of rotator cuff deficiency, but it's not the only one. Sometimes people have greater proximal humerus fractures. Proximal humerus fractures like this one, where there's a greater tuberosity fragment that's very small. Well, the rotator cuff is attached to that little tiny piece of bone. If that piece of bone doesn't heal in the right spot, it essentially mimics a massive rotator cuff tear, and they'll get the same dysfunction associated with that. Additional causes of rotator cuff dysfunction are in failed replacements. So this unfortunate person had half of a shoulder replacement put in for a rotator cuff tear, but this shoulder has lost all constraint to superior migration. So not only is the humeral head not sitting in the glenoid, it's sitting outside of the shoulder altogether. So that force of the deltoid can be so strong that it completely dislocates the shoulder superiorly. So the answer to these problems is a kind of a three-step process. Is number one, we need to create a stable center of rotation to the shoulder. We need to increase the moment arm of the deltoid, make the deltoid work better to lift the arm up. And we need to provide for long-term stability in this. The first two of these were actually figured out in the 70s with this type of shoulder. So this is a reverse total shoulder. The idea was out there that if you put the ball on the socket side of the shoulder and the socket on the ball side, you can create a stable center of rotation. This allows so the arm can't slide upward and it holds things in place. The problem with these designs is they didn't take into account how strong the muscles around the shoulder are. So if the glenoid is way over here, they put the center of rotation way out this way. And these worked for about 3 months. And then they completely ripped out of the socket and they failed. and they failed dramatically. And so this was something that was used in the late 70s and then completely abandoned until the mid-90s. And this guy, Paul Grammont in France, revolutionized reverse total shoulder. And the revolution that he had was, instead of having that center of rotation way lateral, is move it medial. This was his original Grammont total shoulder. It's come on a lot of evolution since then, but the ball is here and the center of rotation is going to be right here. The vast majority of reverse total shoulders are based on this basic design. This is a more modern reverse total shoulder where you have a ball that's going to be on the glenoid side. It has screw fixation. This one has an area for bone ingrowth. There's a stem that's going to be on the humeral side with a plastic socket that's in between. So in a shoulder, it looks like this. So you've got the ball on the glenoid side and the socket on the humeral side. That's the reverse portion of this. The center of rotation is here. This creates a lot more stability. And again, once you switch it around, this humerus can no longer slide superiorly. You've got a stable center of rotation, and the deltoid can lift the arm up. Touch more on the biomechanics. The normal shoulder center of rotation is here. This is what those old designs were trying to recreate, is keeping that center of rotation here. Well, now we end up medializing or moving that center of rotation this way. Not only does it give a stable fulcrum, but the deltoid has a much longer moment arm, and this allows the deltoid to function much more efficiently so that it's doing its own job plus the job of the rotator cuff, so we need to make it as efficient as possible. So we've got this great tool. So when should we use it? Large rotator cuff tears in elderly patients. So as you've heard earlier, rotator cuff tears become much more common as people get older. The quality of the tissue starts to degenerate. And so generally speaking, over the age of 75 or so, rotator cuffs aren't typically repairable. The tissue quality is poor, and this can be a better option. Rotator cuff tears can progress to cuff tear arthropathy, which is a combination of a rotator cuff tear and arthritis, and that's probably the key indication for these. Proximal humerus fractures that are exploded into a lot of pieces. If you can't reliably get that small greater tuberosity piece to heal where it's supposed to, a reverse total shoulder can give you a much more reliable outcome in that situation. As we talked before, revision of failed arthroplasty. If the glenoid component wears out or loosens, or the rotator cuff tears after a shoulder replacement, then a reverse total shoulder can be very helpful. And then much less common, but a tumor resection. If you've got, say, a chondrosarcoma or a large tumor in the upper portion of the humerus that you have to resect, essentially attachment of the rotator cuff, then a good reconstructive option would be a reverse total shoulder. However, there are plenty of times where we shouldn't use this. So in rotator cuff tears, a reverse total shoulder shouldn't be used if physical therapy is able to restore the function. We didn't talk about before is you don't have to have an entire rotator cuff to give the shoulder a stable form. If you're looking this way, if you have an intact subscapularis and you have an intact infraspinatus, and those muscles are strong enough, they can provide that stable fulcrum without a supraspinatus. So as far as expendable rotator cuff goes, the supraspinatus is by far the most expendable. People can compensate for that, especially older people. On the other hand, once you start losing a supraspinatus and a subscapularis, you can no longer compensate, and therapy becomes much less of an option. We also shouldn't use a reverse total shoulder if you can fix the rotator cuff. Fixing the rotator cuff and getting it to heal will be a much better long-term prospect to the shoulder than going to a reverse. So not all rotator cuff tears are fixable, but the ones that are do better when they're fixed. And we shouldn't use it if you can fix the fracture. So proximal humerus fractures sometimes aren't as comminuted, or sometimes they can be repaired. And if you can take this fracture and you can repair it, again, that'll be a much more normal shoulder. And so the bottom line is we should use a reverse total shoulder when we don't have any other options. It is an end-of-the-line operation. There isn't much else that we can do after reverse total shoulder. And so if there are other options exist, use them first. If they don't, this is a lifesaver. When you compare a reverse total shoulder versus an anatomic total shoulder, there are some differences that go with there. A reverse is designed to be used when there is a deficient rotator cuff, whether from a tear or a fracture or previous surgery, whereas Dr. Maletti was talking about, an anatomic shoulder where the ball is still in the ball and the socket's still in the socket, this requires a normal rotator cuff to function well. Because the great vast majority of replacements involve releasing the subscapularis from the front of the shoulder and then repairing it at the end, that has to heal on an anatomic shoulder. And so this needs protection afterwards. So generally speaking, on an anatomic shoulder, it's a sling for 6 weeks. We're protecting the rotator cuff. And then fairly extensive therapy, just like a rotator cuff, to get the shoulder working. On the other hand, with a reverse total shoulder, it doesn't require a rotator cuff. And with more recent designs and more recent biomechanical studies, when we release that subscapularis in the front, repairing it isn't necessary, and some more recent studies show that it may actually be detrimental. Well, that's fantastic. If you don't have to repair it to get it to function, then we don't need to protect it. Again, this is as strong as it is ever going to be on day one. So instead of 6 weeks for a sling, we can start using the sling as needed for comfort. We can allow them to start moving their arm immediately. And because they're not immobilized, they don't get as stiff, they don't get as weak, and often very little or no formal therapy will be needed at all. With standard total shoulders, the general line that we tell patients, this is a pain relief operation. It works well. It will improve motion, but generally not dramatically. In most people with reverse total shoulder, we're aiming for dramatic improvement in function. Like everything in orthopedics, we have our fair share of complications, and one of the reasons that a reverse total shoulder is the end of the road is the complications tend to be more common. Infection is by far more common in a reverse total shoulder than it is in a standard total shoulder. There's probably a couple reasons for that. A lot of these people have had previous shoulder surgeries, and the more surgery you have, the more likely it is to be infected. There's also more dead space, more area for blood to accumulate and lead to infection. Dislocations. Dislocations with a standard shoulder replacement are very uncommon. With the reverse, they can happen. Again, newer implant designs, I think this becomes a little less common, but it is a possibility. Stress fractures. We are technically lengthening the arm as you put in a reverse total shoulder. You're lowering that center of rotation. You're making the deltoid work harder. Well, in older people with fragile bone, that deltoid can pull off a little fragment of the acromion. Again, with some of the newer designs, I think this is improved, but stress fractures can definitely happen. And those are typically people who are doing great, and around the 6-week mark, they have a sudden onset of increased pain. They'll tend to heal, but it can be a setback. And then nerve injury can happen. Again, you're technically lengthening the arm, and sometimes patients can get nerve palsies that do generally resolve, but they can slow down their rehab. And then late loss of function. Europe has been using reverse total shoulders for longer than we have in the United States, and there's been some reports of loss of motion after about 12 years. We think that the deltoid probably just stretches out and the ability to lift the arm up starts to decrease over time. We haven't really done them long enough in the United States to see if this is going to be a problem. It may just simply be a problem of aging, that a lot of people lose elevation as they get older anyway, but there may be a late loss of function with these. So to sum up reverse total shoulder, by changing the anatomy of the shoulder, we can allow it to function without a rotator cuff. This allows treatment for things that we previously couldn't treat before at all. It can be more reliable than other procedures. It's definitely more reliable than hemiarthroplasty in people who have rotator cuff tears. And it can often allow for a faster recovery than other shoulder reconstructive surgeries. But it does come with its own set of complications, so we typically limit this to older patients where there aren't any other options. The definition of older is changing. I think 10 years ago when we started to put these in, there were strong recommendations not to put them in anybody under the age of 70. That keeps creeping lower as we have patients that have unsolvable problems, and we have this option that works, and maybe it won't work for them forever, but it'll work for them now. And so the age group keeps starting creeping down a little bit. And so you can see, this is what's possible. You can see how much happier she is with her new shoulder than with her old one. But we can pretty dramatically improve function in people. The future of reverse total shoulders is interesting. We are transitioning how we care for these people. So this goes along with arthroplasty in general. Usually this was a 2-night stay in the hospital. We're trying to, with better pain control, we can start to shorten the hospital stays and start to do these outside of the hospital in outpatient surgery centers. We have faster rehabilitation protocols that we've started to utilize. I know when I started in practice, they were in a sling for 6 weeks, and I've gotten away from that, and people recover faster. And really recently, we've started to come up with this idea of perhaps a biologic reverse total shoulder. And this is a kind of an exciting, on the forefront of technology, something called a superior capsule reconstruction. Younger people, 45-year-olds, 50-year-olds, sometimes have rotator cuff tears that we can't fix. So if you're looking at this picture down here, this is the greater tuberosity, this is the humeral head, this is the glenoid, and the rotator cuff is somewhere back here. And this gentleman is 45, and there's no way to fix that shoulder. A superior capsule reconstruction uses a dermal allograft, so basically cadaver skin that is tied to the glenoid and tied to the greater tuberosity. And this provides that stable fulcrum. This humeral head can't slide up because this tissue is in place. And so as we start to put it in, we take this same shoulder and we put in our suture anchors that Dr. Backus talked about with lots of stitches attached to them. And we can end up putting in this graft. And this graft can sit on the superior aspect of the shoulder, hold that humeral head in place, and allow people to elevate their arm, even though technically their entire rotator cuff isn't intact. And this is a newer, exciting way to go. And people who, again, didn't previously have an option, they're too young for reverse total shoulder, we can't fix the rotator cuff, this may provide a good solution for them. And essentially it does the same thing that a reverse total shoulder does, but in a biologic sense that we can put in arthroscopically.